Very timely to be talking to you. And we've just kicked off this canine chronic kidney disease summit. And I brought up to the panelists, how are you approaching your clients for these aged pets that maybe have some dental disease that needs attention in the sphere of anesthesia? And I know we're going to have a whole separate talk with that with Dr. Kennedy, but do you have any perspectives about that? Is there a reason other than pain and general health, as far as you know, that not addressing these disease mouths may contribute or potentiate, progression of kidney disease?
Well, we do know Linda DeBose wrote an article many years ago and had a direct correlation between glomerular disease and periodontal disease. And so when you get a mouth that's pretty nasty, and you know which ones I'm talking about, it's kind of like that smells like the penguin house at the zoo when they come in the office. And so these pets, I think that having owners know that there's a risk associated, but we need to do it now versus it getting worse. With that being said, what I do is I talk with the owner and I talk about the potentials for risk, but I tell them that the reward will be good. I look at a bad mouth and I see elevated renal values. I tell them that this is something that's probably contributing to this aspect, and we have to have a decision. Are we going to address it now? Because if we don't address it now, we're not going to address it at all. And I tell them we're not going to have this discussion about guilt a year from now. And that's unfortunate. It's like a tumor. And you see a tumor in the mouth, you go, we've got to address it now. Well, I can't do it now. Okay. They come back in a year. Well, now we feel guilty. Now the tumor is 5 times as big as it was. No, I can't take that tumor out now. And you have to let them know that we need to address things now. And if we can do that now, we can get these kidneys back to at least some semblance of maintenance and prevent that blasting and just constant involvement to the glomerulus of the bacteria in the mouth. And antibiotics are not the answer. Monotherapy is not the answer. You've got to intervene, as far as remove the source of the problem. I think that we should have a righteous fear of anesthesia, and that there are a lot of levels of renal compromise. There are some that are just teetering on potential renal compromise, and then you anesthetize and don't do it properly, and they get pruny, they get hypotensive, and all of a sudden their renal perfusion drops, and you've got a big problem on your hand, and we trigger them into more of an acute renal failure situation. We see a lot of cases in our practice that have high renal values. Well, there are drugs that work very well anesthetically. And so as long as I'm working with Martin, and again, I have that luxury, but still, I think you can still consult and you can refer, but let's just pretend you can consult and ask an internist or an anesthesiologist, I've got this certain pet, what's a good protocol to use? That certain drugs are very renal sparing. And I find that when we anesthetize these patients, as long as we're having good renal perfusion, and we just have to avoid certain drugs that really whack the kidneys, I feel very comfortable. And monitoring is also huge. We have micro pumps in our practice. We have designated 3 micro pumps per patient. So we can have a pet, let's say on a dobutamine drip or a dopamine drip or a norepinephrine drip, one of those for blood pressure. We could also have low dose ketamine, and it's just amazing how true low doses help. We can also have fentanyl and low doses of fentanyl. And so we're running these pumps and all titrating things up to keep renal perfusion and preventing hypotension. So in the renal case, the biggest thing you have to worry about is hypotension. So if you're able to have an understanding and just not necessarily just pull fluids, and you've got to know, have that Doppler ready and have it on that case. In addition to the blood pressure monitors you have, we always have the Doppler as our secondary. And if that pet starts getting hypotensive, it immediately gets a medication to raise that blood pressure. But I do think that I don't mind it. I really don't. I don't mind it because I have a good team. I have a well-educated team so that I know I can focus on what I need to do as a dentist, and they focus on the anesthesia. And so we have a dedicated anesthetist, and then I have a technician that does the cleaning and polishing and assists me in the procedure itself. You have all those ducks in a row. I think that addressing that renal patient can be done safely. And then they have to make sure they go home, that they're drinking water, they're perfusing well. If they need to come back for fluids, watch your NSAIDs to stay away from causing problems, because NSAIDs can cause hypotension. And so if I have a case that's a kidney case, I probably stay away from NSAIDs. But with that being said, the balance between the heart and the kidneys is also one that's very delicate too. And sometimes we have cases that have heart disease that also have renal disease. And then you have to be very careful with fluid balance. And that's especially why you use, medications like norepinephrine or dopamine, dobutamine, where you don't necessarily blow them with fluids because you're going to cause cardiac overload.